Hello and welcome to Health and Living with me, Lim Su An. This is another episode of our mini-series Unpacking the Health White Paper, in which we break down some of the reforms that have been suggested in the recently passed Health White Paper, which lays the foundation for health reforms in the next 15 years and more. Now, one of the key proposals is to restructure the Ministry of Health and to split up the various roles that it currently plays as payer, provider, regulator, and policymaker. Now, what would this look like, and will it destabilize the current healthcare system or provide some much-needed relief to the ministry instead? So joining me on the show to unpack today's topic is Dr. Khor Swee. He's a specialist in health systems and also the founder of Angsana Health. Thank you so much for joining me today, Swee.
Hello, Sue, and it's a pleasure to be back.
Now, for our listeners out there, if you have any thoughts or concerns that you'd like to share with us, you can call us at 77332900. You can WhatsApp our U-Mobile number at 018-789-8899, or you can tweet us at BFM Radio. Now, Swee, maybe we'll start with a very big picture view, right? Could you kickstart this conversation by giving us a brief history of our healthcare system and how our Ministry of Health has developed into what it is today?
So, and this is a great question for which perhaps a short history lesson, I can provide a short history lesson, but for a much more extensive history lesson, I think we need to get some of the stalwarts of Malaysia's health system. So your question is, what is a brief history of Malaysia's health system today? So let's go back to maybe 200-300 years ago, before there was, let's call it a strong colonial system with an evidence-based health system that uses modern science. And at that time, there was a lot of traditional medicine, complementary medicine, the witch doctors or the village doctors or the Chinese sincers and the bomos of the Malay community formed a large part of the health system maybe 200-400 years ago, before modern science and evidence-based medicine came to the fore. Secondly, at that time, there was also this concept of tropical medicine. Tropical medicine came from the Brits because the British soldiers, merchants, and administrators of the British Empire 200-400 years ago needed health in the tropics. So the scientists and the doctors in Great Britain at that time came up with the practice of tropical medicine. But that's like many, many years ago. We fast forward a little bit to 1955 really. In 1955, the first elections in Malaysia were held, and that's when the British transferred over a lot more governance and decision-making to our Malaysian counterparts. Or rather, at that time, Malaya in 1955. And at that time, it's nice to note that it was called the Ministry of Health and Welfare in 1955, at the time around the time of independence. I'm not sure when the word welfare or the responsibilities for welfare was separated away from the Ministry of Health, so I'm not sure about that. And that's the precursor to the modern health system and the modern Ministry of Health in Malaysia today. Finally, I'll add a few thoughts about what has happened since 1957, when Malaysia achieved independence, all the way up to this year. So obviously, it's difficult to summarize 70 years into just a few seconds. I'll try by saying three things. The first one is, the Ministry of Health gradually became bigger and more complicated, for the reason being that healthcare became bigger and more complicated and more expensive. The populations grew, modern disciplines and scientific disciplines grew bigger, more numerous, and also more sophisticated, each of which with their own sets of demands and requirements and also needs. So the Ministry of Health gradually evolved to become very, very big. The second evolution in the last 70 years or so since Malaysia gained independence of Malaysia's Ministry of Health is that the Ministry of Health gradually started focusing less on, let's call it non-health care, meaning things like social welfare has been given over to the KPWKM, or the Women's Family and Community Ministry. The environment was given over to the Department of the Environment, which is under the Natural Resources Ministry, and so on, meaning the Ministry of Health became mostly a Ministry of Health Care, hospitals, clinics, vaccinations, surgeries, and so on, rather than health as a whole, because, naturally speaking, as ministries and governments became more complicated and more sophisticated, they needed to spin off several of these roles. So while the Ministry of Health became bigger, paradoxically, the Ministry of Health started focusing much more on healthcare and less on, let's call it, the social determinants of health. Thirdly and finally, how did the Ministry of Health grow today? Is also to grow to be a little bit more focused on, shall we say, the government provision side. meaning the Ministry of Health in Malaysia has got a strong role in regulating the private sector and setting standards. So it's now played multiple roles rather than the pure healthcare provider role that it started with in the past. So the three big themes of the evolution is MOH got bigger, one. Number two, paradoxically, MOH ceded some functions that are non-healthcare to other agencies. And number three, MOH started playing multiple roles, not just the service provider role that they originally started with. Now, these are three very big themes, of course, over the last 70 years.
Now, I want to focus on that multiple roles aspect, right? Because that's part of what the proposals were part of the proposals that were suggested in the health white paper. Could you walk us through what are these different roles that our Ministry of Health plays, and what is the importance of each of this role in ensuring that healthcare runs smoothly?
That's a great question, Suan, and quite complicated as well. So I'll try to summarize by saying the following. The Ministry of Health plays several roles. The first and biggest role, the one that the Ministry of Health is most recognizable to us, is they provide healthcare services. Example of healthcare services, doctors and nurses delivering vaccinations and surgeries in clinics and hospitals. So the Ministry of Health, the first role, the label for that role is called provider. They're a healthcare provider. And this is similar to many ministries of health around the world. Not all, because some ministries of health don't play the role of a provider, and we can explore this later in the conversation. In Malaysia, the first role is that of a provider. The second role of the Ministry of Health in Malaysia is that it's also a payer or a purchaser. And they're roughly the same things. Let me categorize payer and purchaser into the same category for now. What I mean as a payer and purchaser is there are some roles that the Ministry of Health can't fulfill or doesn't want to fulfill for efficiency reasons. And this is normal, by the way, because there's almost no Ministry of Health in the whole world that does everything by itself. Indeed, to prepare for today's conversation, I checked out the National Health Service in the UK. We all think that the National Health Service is completely government-owned and it delivers 100% of healthcare in the UK, when in actual fact, about 20, depending on how you count it, 20 to 40% of healthcare in the NHS is actually delivered by private providers. In that situation, the NHS in the UK and the MOH in Malaysia plays a role as a payer or a purchaser, purchasing services from the private sector. What sort of services? Think of COVID vaccination programs. So that's the second role of the Ministry of Health. The third role for the Ministry of Health is as a regulator. What do they regulate? The delivery of healthcare in the private sector for private hospitals, private clinics, digital health providers, and so on. And the Ministry of Health does the regulation work by setting policies and also setting enforcement through the Enforcement Division of the Pharmacy Services Division, through CCAPS or Cawalan Kawalan Amalan Perubatan Swasta, which is a private healthcare practices enforcement division. And that's a role of the Ministry of Health to set the regulations and also to enforce those regulations. Now, those are three roles. Fourthly, the Ministry of Health makes policies. And fifthly, the Ministry of Health will also conduct training. There are some Ministry of Health colleges that are slowly being phased out, actually. But for the longest time, Ministry of Health owned colleges, not the Ministry of Education, but the Ministry of Health owned colleges that trains nurses and paramedics. And this is another function of the Ministry of Health in Malaysia. So in summary, there are five perhaps big roles. The first one is as a provider. Secondly, as a payer purchaser. Thirdly, as a regulator. Fourthly, as a policymaker. Fifthly, as a trainer. And perhaps underlying all that, right, setting standards for everything that the Ministry of Health does.
What would you say are the advantages or even the disadvantages of having all of these roles under one roof? Because like you mentioned, not every Ministry of Health around the world sort of have all of this under their purview, right?
This is true. Let's look at some international examples first, and then I'll come back to the question, Sue-Ann. So just for fun, some ministries in other countries are named with different names. For example, in India, it's the Ministry of Health, Family and Welfare. In Japan, it's the Ministry of Health, Labour and Welfare. In South Korea and in Taiwan, it's the Ministry of Health and Welfare. And in Thailand, it's the Ministry of Public Health. Now, there are many other examples of different names, but you get the theme for health plus something else, or sometimes just health alone. So different countries have organized their administration of healthcare in different ways. Now, setting that aside and coming back to your question, which is what are the pros and cons, right? Maybe I'll give 2 or 3 pros and cons in a bit of a list without the analysis, yeah? So what's the con of centralizing everything in one? On paper, that organization can see everything, in the sense that because I own all the functions, I can see what the gaps are, I can interconnect the gaps, I can make sure that whenever I introduce one policy, it's applicable to many other disciplines and not just siloed in one particular discipline.
Mm-hmm.
That panopticon role, or the very universal visibility role, these are just my terms, right? For the Ministry of Health to see everything gives it a very strong advantage in trying to implement policies that are holistic, comprehensive, and leaves no stone unturned. I think that's one big benefit of a large Ministry of Health that can, let's call it, see everything. But there are also disadvantages of a large Ministry of Health. And here I want to talk about global banking, especially after 2008. In 2008, there was a global financial crisis. It was so big that they give it capital G, capital F, capital C. So it's a GFC, global financial crisis, that introduced a new term to us, that banks can be too big to fail. Another corollary to banks being too big to fail is that banks around the world could be too big to understand, meaning it is so big that sometimes they find it difficult to govern. Now, I'm not advocating for a smaller or a larger MOH. That's not my intention over here. I'm answering the question, which is what are the pros and cons. The pros is a comprehensive MOH can see everything with all functions under one roof, but if you have all functions under one roof, you have two main challenges, as in you become very big and therefore it's very challenging to govern a very large entity. Example, the National Health Service, right, in the UK, it has a 1.1 or 1.3 million employees in the NHS. They're not really governed centralized. It's actually quite decentralized. And in Malaysia's Ministry of Health, 270,000 people inside the Ministry of Health in Malaysia, and sometimes that can be quite difficult to govern as well. There's a second challenge, or second, let's call it, disadvantage of a very centralized system with all functions under one roof, and that is a potential conflict of interest. That perhaps requires a bit more elaboration, which I can provide perhaps shortly.
Talk to me more about that conflict of interest, right? Because I'm assuming it links back to all the different roles that we were talking about earlier that the MOH plays.
Of course, it does link back to the multiple roles that the Ministry of Health Malaysia plays at the moment. So I'll describe this in theory, because many ministries of health around the world also face this problem, the problem of potential conflicts of interest, not actual. By no means am I saying that there are on no conflicts of interest. I'm saying that there are potential conflicts of interest in the way a health ministry is governed and organized and administered. In that sense, therefore, Malaysia is not different from other countries that have got multiple functions under the same umbrella of the Ministry of Health. This is so that's my first analysis, which is Malaysia's in the same boat as many other ministries of health, and all of us are trying to de-conflict or to remove our potential conflicts of interest. Here's several examples of the potential conflicts of interest. The first one is if I'm the provider and I'm the standards setter, there could be a potential conflict of interest in the sense that I might set standards that are matching actual performance instead of setting standards that are ambitious and, let's call it something for us to aspire to, aspirational, that is the word I'm looking for. What I mean to say is, instead of setting standards that are matching what we're currently providing so that we can tell people, hey, we're meeting standards, we should be setting standards that are aspirational so that we can try to meet consistently, progressively higher standards. So that's one example of, say, the potential conflict of interest that any Ministry of Health is dealing with, perhaps even including Malaysia's. The second example of a potential conflict of interest is the regulation and the enforcement of the standards. In many countries, here's a fun fact, right? There are 85% of Japanese hospitals are privately held. To repeat, 85% of Japanese hospitals are privately held. It's 85% plus minus around that number. It depends on what you mean by private hospital, it depends on what you mean by hospital, and so on, right? But it's a large number is the point. And those hospitals are privately held, but they are non-profit. It's a beautiful concept that you can be a privately held hospital and non-profit rather than for-profit. I bring up this example of Japan to answer the question of potential conflict of interest. To link the two is like this. If all the hospitals in a country is privately held, or most of the hospitals in a country are privately held, it means that you can enforce the same standard, meaning everyone must have the same look and feel for what the emergency department is like. There is something called a door-to-needle or door-to-balloon time, which is every time somebody comes to an emergency department with a heart attack, you must give an intervention to this person within an hour of the person getting a heart attack. Within an hour, the person arriving at the emergency department. Now, that standard, or the door to needle or the door to balloon time, is taken as a percentage, meaning I treat 80% of my patients who arrive with a heart attack in my emergency department within an hour. That standard can be applied uniformly for all hospitals if there's no real distinction between public and private.
Mm-hmm.
However, in Malaysia and in many other countries as well, actually, is to say that the government sets a rule and then the private sector must follow the rule, but not the government sector. Now, that is a potential conflict of interest. So I've given two examples of potential conflicts of interest in the different roles that any typical Ministry of Health might play.
All right. On the show with me today is Dr. Khor Kheng, specialist in health systems, and we are unpacking the recent health white paper, or we'll get to that after when we come back from the break, and we want to dive into the proposals to reform the role of the Ministry of Health. We'll be right back after a few messages, so keep it here on Health and Living, BFM 89.9. Welcome back to Health and Living with me, Lim Su, and we are continuing our coverage on the Health White Paper, which was passed recently in the latest Parliament sitting. And joining me on the show today is Dr. Khor Kheng, specialist in health systems. He's also the founder of Angsana Health. Now, today we are focusing our discussion on the proposed restructuring of the various roles of the Ministry of Health, and thus we want to get into what the future of MOH might look like when these reforms are set in motion. Now, before the break, Swee Kheng was sharing a bit, taking us down a bit of a historical path, looking at how MOH came to be and the various roles that it currently plays. Now, before we get into the proposals in the Health White Paper, Swee Kheng, why do you think there has been that need to restructure the various roles of the Ministry of Health? Is the current system not sustainable?
And that's a complex question with a lot of interlinkages. If I break it down to two, why do we need to restructure the roles of MOH? And the word restructure could be used differently as well. You could restructure, realign, change the operating structure. We can find the right word, but for the purposes of today's conversation, I'll continue using the word restructure without trying to tell everyone that we're going to dramatically transform, right? Because and also maybe the important caveat over here is speaking in my personal capacity and not representing any organization whatsoever. The second part of your question is about, is the current system unsustainable or untenable? And the answer to that question is potentially yes, the current system is unsustainable. The question about sustainability is often a question about money, as in, how can we mobilize more sources of funds and then use those funds appropriately for better healthcare? So when it comes to financing, it's usually often a question of what are the sources of funds and what are the users of funds. And each topic or sources or users actually deserves perhaps an entire show all by itself. Let me set that aside. That's the second question about is the current system unsustainable? And perhaps yes, and perhaps it's financial, that we need more money to be able to pay for better healthcare and better health for our population. Now, to the first part of the question is, do we need to restructure the roles of Ministry of Health? Perhaps yes. Maybe the word is not restructure. Maybe the word is realign so that we can deconflict the Ministry of Health, so that we can optimize the functions of the Ministry of Health to allow the Ministry of Health to be more future ready. Now, how do we bring the two together from a public administration perspective, as well as from a financial perspective? How are they interlinked? Many people might say they're interlinked in this way. Having asked that question, I'll now answer it. Money and public administration is interlinked because if we continue providing larger sums of money to an inefficient system, then we'll only be increasing the risk of wasting the money. Mm-hmm. Now, this is not any judgment on any organization whatsoever. I'm merely stating a point in abstract reality. The point I'm making is that if any organization, any Ministry of Health, any company anywhere in the world is not able to appropriately utilize this money, or the organizational chart as well as the organizational structure is not efficient, effective, and capable of delivering results, then throwing money at that inefficient structure will only lose us money. So anybody can say, let's increase Malaysia's GDP to Malaysia's health spending 10% on GDP. Nobody's saying this, by the way. I'm just saying anybody can say, let's increase to 10% on GDP. And I might caution to say, okay, perhaps not. Why? Because the system is not able to absorb so much money coming into the system all at once, therefore increasing the risks of corruption, wastage, fraud, and abuse.
Mm-hmm.
So therefore, money and organizational charts are tied together with a good, better, future-proof, say, org chart and a structure. Then we're able to accept even smaller amounts of increases, right? And then we can use the money a lot more efficiently and effectively. So why is there a need to restructure the roles of MOH? Firstly, to make it more efficient. Secondly, to remove and prevent conflicts of interest. Thirdly, the health system that Malaysia has built today was organically built since 1957. The short answer to the question of why do we need to restructure, realign, optimize the roles of MOH is actually the system that got us here today is not going to bring us tomorrow, meaning the disease burdens of tomorrow are very different from the disease burdens of 30, 40, 50 years ago. And therefore, this is a good opportunity through the Health White Paper and various other initiatives by the Ministry of Health and the government to appropriately optimize the role of the Ministry of Health.
It's almost like an evolution of the Ministry of Health, isn't it? So let's look at the proposals in the Health White Paper. Right now, one of it which got quite a lot of attention was the suggestion of splitting off its role as the provider of healthcare services to give more autonomy to the various government health facilities, the hospitals, the KKs across the country. Now, we don't have much in terms of details, but looking at the possibilities, what might this look like for healthcare facilities? What might that mean in terms of how they're able to function compared to how they do now?
Suan, thank you. To begin answering this question is to introduce a caveat again that I'm speaking in my personal capacity and not representing any organization. Second caveat is to say that the Health White Paper is a high-level statement of intent, and it's great first step for it to be passed in both houses of parliament, kicking off our 20-year reform journey. A lot of things can happen in these 20 years, and the specifics will need to be worked out by very many experts, including from the public sector, academic sector, private sector, NGO sector, and so on. So meaning we can co-create as a country the health system that we need and want and deserve. So, and with those caveats in mind, your question is, what might it look like for a public hospital, let's say Hospital Taiping, where I'm from. I'm from Taiping. So, and I served in Hospital Taiping as well. So let's use Hospital Taiping as the example, okay? Currently fully owned by the Ministry of Health. The land, the building, the assets, the CT scan machines or MRI machines as well in the Hospital Taiping are fully owned by the Ministry of Health. What happens then? So here, I will bring an example of Singapore General Hospital. For very many years, the Singapore General Hospital in Singapore was fully owned by the government. The land, the MRI machines, everything is fully owned by the government. Then around in the 1990s, there was a law that was passed that transferred ownership of all of Singapore General Hospital's assets into a company that's incorporated as a private limited or Senjam Berhad, which is the equivalent of private limited in Singapore, that's called Sing Health. Or Singapore Health. Who owns Sing Health? MOH Holdings Private Limited. Who owns MOH Holdings Private Limited? The Ministry of Finance of Singapore. Now, that particular model is something that Malaysia has done before in Institute Jantung Negara. Institute Jantung Negara, the land, the building, and its assets, and also human capital, salary structures, and so on and so forth, are operated as a private entity, which is then fully owned you know what? I'm not sure if it's fully owned or partially owned, but the Ministry of Finance Incorporated in Malaysia has a very high stake, if not the full controlling stake, if not the full outright stake in Institute Jantung Negara. The point being that Malaysia has done this before in one situation of Institute Jantung Negara. And that's a model that Hospital Taiping could potentially go to as well. That's on the ownership side, transferring it to a private entity that is fully owned by the government. Now, you might say, okay, why transfer to a private entity when the government can own it outright? And the benefits for that would be some amount of autonomy that's given over to Hospital Taiping. There will be subsidies that will definitely be given over to the, say, the B40 community and people who, after appropriate means testing, is able to show that they need help from the government. So all of this is to say that from an ownership perspective, it is neutral to the poor because the government can continue subsidizing the poor. What about, secondly, on a payment and subsidies perspective? Instead of the government of Malaysia pumping money into say hospital typing and the equivalents of hospital typings around Malaysia, the conversion of hospital typing into a private company means that hospital typing will now need to be much more responsible in managing the funds, because they are responsible ultimately for making sure that they don't lose money at the end of the year. The objective of Singapore General Hospital, let's return to Singapore for a while, the objective of Singapore General Hospital is not to profit. Even though they are a private hospital, their objective is not to profit. Of course, their objective is to run the hospital well and efficiently and without wastage and fraud and abuse, and then to maximize every dollar that the government of Singapore provides to Singapore General Hospital. But the objective and the purpose and the intention is not to make money. Similarly, the ownership can be roughly similar to what Singapore has done, to what Japan has done, to what South Korea has done, to what Germany has done, and to what Taiwan has done, which is a private hospital that is privately held by an entity that could be the government and is run on a non-profit basis, but allowing it to adopt more modern management practices. And that's on the ownership side and also the payment side. I think these are the two more important elements of let's call it the corporatization of health services, not so much the privatization of health services. Now, to repeat, there are many examples of countries with private hospitals that are government, in a sense, owned by the government, or private hospitals that are privately run on a non-profit basis. Malaysia's, we actually have some hospitals in Malaysia actually that are private hospitals, privately owned, run as non-profits. Asunta is one example in Petaling Jaya. Fatima is a second example in Ipoh. Adventist is a third example in Penang. And these are three, and there are actually many more examples of privately held non-profit hospitals in Malaysia. So it's not a model that's unfamiliar to the rest of the world. And I think that to say that all hospitals are private and therefore profit-making is a bit of a straw man argument and has no basis in fact.
So is this essentially decentralization then, which what many people have been calling for in terms of how we can improve the healthcare system?
Strictly speaking, no. So the corporatization and decentralization means different things. It could be that you're corporatized, but then still very, very heavily centralized in terms of all the hospitals are dependent on funding from the government. All the hospitals are dependent on human capital and salary structures from the government. So essentially, even though on paper, in name, hospital typing, for example, is already privatized, but completely dependent on the government, then that's in decentralization terms, that's not meaningful. There are several ways that we can decentralize though. Decentralization can be political, fiscal, administrative. Political meaning we allow decisions to be made by state health departments, in example, Ipoh, where the Perak State Health Department sits, and hospital typing at the district level, or even the district health office of Larut Matan dan Selama, which is the name of the district. So we can decentralize politically, meaning the decisions, political and public health and scientific decisions, staffing decisions, how many doctors do you need, how do you deploy your resources, all decentralized. At the moment, it's not really. Malaysia is not really decentralized yet because a lot of decisions are made in Putrajaya. Going back to the fiscal decentralization, meaning the decisions for budgets are made at the state level or district level or the hospital level. And for administrative, decisions of how to allocate resources are decentralized away from Putrajaya to the state government, district government, or even the local government, for example, or local hospitals. So that's the difference between decentralization and corporatization. Decentralization is, let's call it more decision-making. And corporatization is more who owns the physical assets and how's the legal and operating structure of the particular hospital.
One more quick point on this on this issue is: are there any potential pitfalls when it comes to this idea of corporatization? Because right now we have MOH sort of overseeing everything, coordinating resources when necessary, moving things, human resources if needed. If we sort of go down this corporatization route, would we lose that sort of big figure, that figure at the top being able to coordinate things smoothly?
This is a great question. And corporatization, decentralization, and shall we say the more autonomy for government health facilities is not a magic bullet, magic solution, magic overnight unicorn. It's not that. And there are also problems with that kind of corporatization and decentralization as well. Let me share two thoughts, one short-term and one long-term problems, let's call it, yeah? The short-term problem is it is possible that any state government, or not state government, but state health department, district health office, and the hospital level, they are quite used to receiving instructions and them carrying out instructions. Therefore, in the short term, we cannot shock the system by transferring 100% of all responsibilities and distributing away from Putrajaya to, say, to Ipoh or to Taiping, for example. So it must be gradual with capacity building, giving people the tools, the confidence, the capabilities, the training, the empowerment to make decisions, and also the accountability to make sure that decisions are made well. So that's one short-term problem, which is capacity building. In the long term, another problem could be inefficiencies, paradoxically. Why? Because there's a lot of competition, introducing too much competition within the system, and having too many competition for resources is one thing, and a non-aligned public health strategy. How can we circumvent these two problems? Firstly, in the short term, lots and lots of capacity building. Number two, gradually transferring, and then piloting, testing this out, experimenting. Instead of making a decision on Monday, and then Friday we're transferring everything. I don't think that should happen that way. It should be as gradual as 10 years. And as gradual as hospital to hospital, as gradual as transferring, I give you 3 responsibilities in year 1, another 3 responsibilities in year 2, and so on. It should be very, very gradual. So that's one mitigating say action. The second mitigating action to resolve those problems, right, is actually to have a strong Ministry of Health central function, but with limited, say, capabilities, but responsibilities. Meaning to say, the Ministry of Health in Putrajaya should really be responsible for public health overall, meaning they coordinate all the public health activities all across Malaysia. This is what Public Health England does over and above the National Health Service. Number 2, Ministry of Health in Putrajaya can set standards, meaning Hospital Taiping, Hospital Sarawak, Bintulu, Hospital Sandakan, Kota Baru, for example, will need to meet a set of standards. Who set those standards? Putrajaya. Now, because Putrajaya is setting those standards, other, say, in Perlis and in Kuantan, they will have to follow the standards that are set by somebody other than themselves. So I'm not setting the standard and I'm following my own standard. It's more other people setting the standards and I will follow the standards, and then there should be audits as well. So as central function, at least 2 functions, which is public health coordination, and number 2, setting standards. And of course, the enforcement and the regulation standards as well. Thirdly, there should be a policy-making function inside the Ministry of Health. Now, these 3 central functions of public health coordination, standard setting, and policy making is similar to what the headquarters for health policies would do in Japan. It's similar to what the Ministry of Health in Singapore actually currently does. So the MOH in Singapore, they operate no hospitals because the hospitals are all privately owned entities that are fully owned by the Ministry of Finance.
All right. Now, moving on to another point in the health white paper, which was the suggestion for the role of MOH as a buyer or as a purchaser to be split off, and the introduction of a strategic purchaser. Maybe you could briefly walk us through what that role of a strategic purchaser is, and how significant is that to take it out from MOH?
First, thanks, Suen. Firstly, what is strategic purchasing? Well, the short answer for strategic purchasing is purchasing that maximizes the value of your dollar, more bang for the buck. It's just a nice fancy term for getting maximum value for your dollar, or ringgit in this case. So the word strategic purchasing, the term strategic purchasing is just a nice name for getting more bang for your buck. Let me set aside the definition of strategic purchaser and talk about how is Ministry of Health currently purchasing their items. And there's a procurement unit inside Unit Perolehan inside the Ministry of Health. The Unit Perolehan is managed more by the Secretary General, not the Director General. So it's an administrative function rather than a clinical function or a technocratic function. So therefore, if a doctor wants to buy anything, of course, there are allocations to the hospital level and so on. And I'm not talking about the allocations. I'm talking about if a doctor wants to buy, let's say I want to buy an MRI machine, for example, and I'll put this in my hospital and it costs 10 million ringgit. I need to raise a request to the Unit Perolehan, who then aggregates all the requests from all around Malaysia and then purchases the item. So that's what that's how purchasing is currently happening inside the Ministry of Health. Thirdly, is to introduce the existence of Protect Health Corporation Sdn Bhd, fully owned by the Ministry of Finance, and Protect Health was set up around 2016 And the role for Protect Health is to support the Ministry of Health in aggregating services and also to purchase services. Here's an example. Protect Health was very instrumental, crucial, fundamental. They did a really good job in the COVID vaccination program, where Protect Health gathered general practitioners, organized the general practitioners, contracted the general practitioners, and then money came from the Ministry of Health to Protect Health. Protect Health paid the general practitioners. And that's the function of a strategic purchaser, aggregating demand and then providing that service to the Ministry of Health. So finally, it's to come to the question right now. Perhaps the health white paper doesn't envision that a strategic purchaser should be spun off from the Ministry of Health. And there are multiple possible permutations over here. Now, purchasing is obviously important because we want to avoid corruption, wastage, fraud, and abuse. And corruption, wastage, fraud, and abuse are massive problems in purchasing. So the strategic purchaser needs to be very strongly governed. It doesn't matter whether or not the strategic purchaser is inside or outside of MOH, as long as it's well governed. Because the budget for health in Malaysia to buy drugs and equipment and purchase ambulance services and so on is in the billions of ringgit a year. So I am agnostic as to whether or not the strategic purchaser sits inside MOH, outside MOH, as long as it's well governed with transparency and accountability to make sure that there's no corruption, wastage, fraud, and abuse. Everything else is a matter of public administration.
So it's a matter of just ensuring that there's check and balance, isn't it?
Absolutely, Suan. Thank you.
All right, we'll go for another quick break, and when we come back, we will wrap up our discussion for today. On the show with me today is Dr. Khor, Kheng, specialist in health systems and founder of Angsana Health. We'll be right back after a few messages, so keep it here on Health and Living, BFM 89.9. Welcome back to Health and Living with me, Lim Su An. Joining me on the show today is Dr. Khor, Kheng, specialist in health systems and also founder of Angsana Health, and he's joining me to unpack the health white paper. And today we are discussing the proposals in the health white paper to restructure, or perhaps rather to realign, the various roles of the Ministry of Health. Now, just one more thing, Kheng. The health white paper also says that the Ministry of Health in the future will focus more on its supervisory, regulatory and policy-making role. You've touched on that a bit through our conversation, but if we could focus on this for a bit, what do you think needs to be strengthened or reformed when it comes to these functions, especially considering the current needs of our healthcare system?
Wow, a very complex question to answer, Instead of giving a laundry list, I would like to point us to the 6 building blocks of a health system. And the 6 building blocks of a health system is from the World Health Organization. And we can Google 6 building blocks, 6 building blocks of a health system, World Health Organization. Will get a very good set of information about the 6 building blocks. Your question is about what can the Ministry of Health do to strengthen its supervisory, regulatory and policy-making role. With that 6 building blocks in mind, we can then organize what each of the focus areas could be. Let me give one example per block, okay? The first block is, in random order, the first block is human capital. Ministry of Health perhaps needs to change or strengthen the way we are organizing our human capital. Meaning, is there a way for a Health Services Commission or even the Ministry of Health to take over the functions of hiring and firing away from Jabatan Perkhidmatan Awam or the Public Service Division? That's one example of strengthening supervisory, regulatory and policy-making role. And that's got some public administration elements to it as well. I'll give maybe 2 more examples. The second building block is that of medicines, vaccines and technologies. Can the Ministry of Health do more or strengthen the way the Ministry of Health approves medicines and devices before medicines and devices are used in the Malaysian population? One more thing actually, digital tools, meaning can the Ministry of Health create a software as a medical device regulatory approval pathway similar to that of Germany and Singapore? That's the second example of how the MOH can strengthen its supervisory, regulatory, or policy-making role. Thirdly and finally, it's about leadership and governance. The third of 6 building blocks is about leadership and governance. So what the MOH can do in terms of leadership and governance is to create a public administration system where the Ministry of Health will be able to have a dashboard of hospital performance and public health performance of all the 145 public hospitals in Malaysia, including the 200 private hospitals in Malaysia. One centralized dashboard that allows the government, the Ministry of Health to have a look at the informatics as well as then be able to govern and lead the health system. By the way, these are three examples that touches 4 of the 6 building blocks. Human capital is one, medicines, vaccines, and technology is the second building block, and the third and fourth building blocks are leadership and governance and health systems information.
What is the role or should be the role of the Minister of Health in all of this? Because, as we've seen in the past few years, governments change, ministers of health change. How do we account for that change at the top without it impacting all these reforms that could be planned down the line?
Suan, thank you. Suan, you just want to hear it correctly. You said the minister, the person, the individual
Yes.
of health, right? Got it. Okay, we'll start with a fun fact. The fun fact is that since 1955, Malaysia has about 23, 24 health ministers. Therefore, we've changed health ministers once every 2.5 years or so.
Mm-hmm.
So in any given job, many of us have changed jobs before, right? We move from one company to another, we get a new promotion. Usually in the first year, we learn on the job. And then the second year, we're able to contribute. And then it's time to go for the Minister of Health. So it is rather unfortunate that it's a reality of life, really, and I accept that reality that ministers may come and go. So I think Minister Zaleha has been very generous in following on from the footsteps of her predecessor, Minister Khairi, meaning to say, and kudos to Minister Zaleha over here, she continued on with the health white paper that was started by the previous minister, which was good. And even though they, in a sense, belong to, let's call it a different political coalition, or maybe the same political coalition, sometimes it's quite confusing. The point being that the current minister followed the footsteps of a previous minister, and long may that continue, because health reforms will take 15, 20, 35 years or so. And it's not a one-year process that can be finished in one term. Even a parliamentary term or a prime minister's term, certainly not a minister's term. Mm-hmm. So the analysis over here is that because ministers come and go and change relatively frequently, while we hope for some stability for reforms to take place, no minister will stay in power in the health portfolio for 25 years to supervise reforms. Therefore, it's important to continue what the predecessor has done. To do that, we will probably need an entity that was previously proposed by the Health White Paper, which is a Health Reform Commission to guide and supervise reforms over a period of time, and then to end its terms of reference, and then perhaps pass over to a Health Services Commission. I've previously written about this, including several years ago, and this Health Reform Commission could be that entity that's responsible to Parliament, created by Act of Law. It would be similar in spirit to the National Health Commission in Thailand that started in the late 1990s. In the National Health Commission of Thailand, it is beautiful, was in Thailand recently and spoke with some members of the National Health Commission in Thailand, including the Consumer Association of Thailand, which I think is really awesome.
All right. We're definitely going to revisit this conversation as and when more specifics are set out in terms of how these reforms would be set in motion over the next 5, 10, and 15 years. But I guess when that does happen, right, when we do start seeing these reforms being put in place, changes being made bit by bit, how will we know then when these reforms are working, when the healthcare system is functioning well?
What a great question, Suan. I don't have a good answer to this question, I'm afraid. The spirit of the question is, how do we know that reforms are working? Let me give you a proxy answer, yeah? My best attempt at an answer is, to know if reforms are working is to know if our health system's performance is improving. Now, improvement may be a lagging indicator, meaning you make a change today, you can only see the benefit perhaps 1 year, 3 years, 5 years into the future. Because health is not something that you do something today and then tomorrow you have a benefit, right? A classic case in point is the medical student. The medical student comes today in first year of medical school, reads a textbook that was recent today. By the time the medical student graduates, the textbook is obsolete already. So that kind of a lagging indicator for success is a problem in measuring the effectiveness of reforms as well. Short answer is, I don't know. I'm going to come back to you. I'm going to do my research and do my thinking. I'll come back to you. The proxy answer is, to know if reforms are working is to see if the health system is improving. Now, there are some things, this one I have a better answer. There's something called summary measures of population health. A summary measure of population health is to see things like, How many are we living longer? Currently 72 years old, and therefore we're living a bit longer, and therefore health reforms are working. Second example of a summary measure of population health is percentage of children aged 6 and below who have received the DPT3 vaccine, or diphtheria, pertussis, tetanus 3 vaccine. Malaysia's at 98%. If we can increase that to 99%, we can know that reforms are working. The third example of a summary measure of population health is the percentage of Malaysians who are bankrupt because of a health problem is now about 20%, meaning 20% of Malaysians who are bankrupt, 100 Malaysians go bankrupt, 20 Malaysians go bankrupt because of health reasons, medical costs, and so on and so forth. So the number from 20 reduces. Now, health reforms as a whole, right, can sometimes be invisible, as in there's no direct correlation to say that I reform this and fewer people get bankrupt, reform that, more people get vaccinated. It's very difficult to draw a direct straight line causality. Therefore, because of the complexity of it, we must need a composite, a group, a set of summary measures of population health. A fun way, and I'll end here, Swee, before passing back to you, is to know if a health system is working. We look at quality, access, and cost. I mean, it's more complex than that, right? We also look at outcomes, user satisfaction, financial risk protection, summary measures of population health. But a simple layperson way to understand if a health system is working is QAC, or quality, access, and cost. Higher quality, higher access, lower cost, reforms are working. And an even easier way to remember quality, access, and cost, or efficiency, effectiveness, and equity, the easier way is to remember good, fast, and cheap. Healthcare becomes gooder, healthcare becomes faster, healthcare becomes cheaper.
All right. Thank you so much for joining me today, Kheng.
Thank you, Swee.
I've been speaking to specialist in health systems, Dr. Khor about the health white paper and the proposals to realign the roles of the Ministry of Health. I'm Lim Suen, and this has been Health and Living, BFM 89.9.